What are the key challenges facing consultants at the moment?
I think consultants across the country are facing multiple challenges, particularly trying to deliver the government targets of 18 weeks from GP referral, A&E targets, hospital-acquired infection targets. Consultants are feeling under intense pressure, but also many consultants are seeing this as a substantial opportunity to really take the lead and show their trusts how best to deliver care for patients. On a wider scale, we see the DARSA review, which is going ahead across London, and the Next Steps review across the whole country, where consultants are beginning to get involved. That is a challenge for us, but it's also an opportunity for those consultants really to take leadership positions and show the best way of getting the highest quality care for their patients. But this is patchy, and it is vitally important that consultants strive to get involved and make sure that this review is the start of an ongoing process. At this current time, a lot of consultants are also intimately involved in the specialty training appointment system, helping juniors at a very testing time. It is vital that consultants have the time available to ensure the best appointments, but also the strongest possible support for our junior colleagues who are the lifeblood of the future of medicine.
Do you think the government is listening to the views of doctors?
I think the government could listen better, but it's beyond just listening. It's about communicating. It's about having a two-way dialogue, an ongoing dialogue, not just at trust level, but at regional level with strategic health authorities and at national level with the politicians, ministers and the Department of Health. At national level, yes, I do believe they are listening to us, but we are yet to see a lot of that being put into action. We have good contacts with ministers, with the Department of Health centrally, but we very often see at our local level consultants frustrated at the fact that some of the central pronouncements are not being delivered at the local level, where they're focusing far too much on short-term targets rather than a long-term gain.
Can you give me any examples of where the government has already listened to doctors and has perhaps changed its policy on any of the key issues?
We've been pushing very hard for consultants to be put at the forefront to take up leadership positions. We're now getting strong messages centrally that they wish to see consultants taking those leadership positions, getting the right reward and support for doing so. That they wish to see consultants at the highest positions within trusts taking forward care for patients. On specific issues such as payment by results, we pressed very hard from the outset that this needed to be made more specific. We're seeing those changes. We've seen the reports last year and this year showing that that change needs to continue. We've seen the Audit Commission showing that it's only by getting clinicians intimately involved in this process that you get accurate information and trust can be really financially successful. We can see with the Took report, with the response to the disaster of MTAS and the MMC procedures last year, that with the review group and now the programme board, that the government is listening to the profession, providing more training places, providing more resources to try and resolve the catastrophe that they set up by not listening to us at that point. So there are multiple examples of how they are listening to us, but they need to listen more because they really want to have the highest class and excellent healthcare. They need to see that consultants can deliver that for them.
The government has said that it wants more care to be provided closer to patients' homes, which will mean transferring some services away from hospital into the community. Will consultants be forced to work differently in the future?
I think consultants have always adapted how they've worked to the best evidence, to providing the best care for their patients. If we look at cardiologists, many of them already provide large amounts of their service with community teams, working with their GP colleagues out in the community for heart failure, for example. Our respiratory colleagues, similarly, much of chronic obstructive pulmonary disease is managed out in the community. We see diabetologists doing similarly, and many other clinicians moving their care to where the best evidence is. But the government has hooked up onto something we believe is driven more by finance than the best evidence. And consultants will apply the best evidence, work in collaboration with patients, and where it is safest to deliver care. So where it is safest to deliver care, yes, it can be moved from the traditional secondary care bricks and mortar more out into the community. But in other circumstances, the local district general hospital may be the closest point to home for that urban area, and that is the best place, and the most efficient, cost-effective place for that care to be provided for patients. There is not one size that fits all, and we certainly mustn't just go for the cheapest option. Let's follow the evidence, and consultants are best placed to do that.
Are you worried about the government giving the private sector a greater role in providing NHS services?
Let's take this one on head on. There's always been provision in the private sector working with the NHS. Many consultants are involved in the private sector undertaking traditional private practice. Many consultants have been involved in waiting list initiatives, report writing, all technically part of the private sector. However, we've taken a strong and consistent line on this, that the introduction of more private sector should only be done where the NHS needs it, where the NHS can't do better or it's more cost effective doing it that way. It should be done in continuity and collaboration with the NHS. And we've seen the ISTC Independent Sector Treatment Centre programme radically cut back in secondary care. Third wave cancelled, secondary wave very much less. We're seeing providers only this week cutting back on their strategic positions as far as providing NHS care is concerned. And that leaves the private sector providing care where the NHS needs it, where there's a short-term need for enhancing capacity, or where the NHS, working in partnership, can get best value for patients. Throwing the hand grenades of private sector involvement into the system with independent sector treatment centres, with CATs, capture assessment and treatment centres, didn't work, was very disruptive. We only hope that the government will listen and learn from that in its latest bright idea of polyclinics, and see that it should be providing the best evidence, working with doctors in particular, but also other clinicians in health service, in partnership with patients, on where the best evidence is to provide cost-effective, high-quality care.
Some people are proposing a new grade of doctor, a sub-consultant grade. Do you support this move?
No, we've taken a very strong line against this. We feel it's not good for patients, it's disastrous for juniors coming through training, and it's also a potential threat for existing consultants. What we need to do is develop the consultant grade, promote the use of the new 2003 consultant contract, and allow consultants to innovate and show how they can best deliver the highest quality care as consultants. The certificate of completion of training should be exactly that. We need to enhance the assessment during training to ensure that trainees are up to the standard, which we believe they are, to take on consultant posts. And we also need to enhance the alternatives to consultant or GP principles as the endpoint of training, to ensure that those that wish to take a step out of the standard track are truly valued in their position as staff and associate specialist doctors or specialty doctors.
Do we need more consultants in this country?
Yes, we do. There's good evidence that we need an expansion of the consultant numbers now in many areas: obstetrics, trauma, A&E, acute medicine, delivering care to patients, enhancing, following the evidence of how best to enhance care for patients. That expansion needs to come now and will help those who are coming off the training schemes to take up the consultant posts we know patients need.
How can consultants become more involved in the BMA and express their views to the CCSC?
Consultants are the lifeblood of the CCSC. We strongly advocate that they get involved, both locally through their medical staff or medical advisory committees, their local negotiating committees. We work closely with our LNC chairs, helping them, supporting them, providing the best ways they can help their local consultants, but also us nationally. From their medical staff committees, coming up through our regional committees, those elections will be coming up shortly, and we look forward to new lifeblood coming into the CCSC each year in September as our new session starts. Centrally, we both work with our regional representatives and our local representatives, but also seek direct information from surveys and emails to and from our membership, so our policies best reflect what consultants on the ground need. The more that consultants get involved, the better we can help them to help deliver the high quality services we know they wish to deliver for patients.